right now, the biggest challenges are one, the screening, to be able to identify the recipients of care that are at risk or already have HD. And this could be clinical screening. And so there are still gaps in terms of capacity, skills, knowledge of the health workers, but also laboratory screening in terms of the resources available to most of the health units, knowing that HIV is now treated in the lowest, up the lowest of the health facilities in most of the health systems. Many of them do not have the requisite tools and resources to be able to screen for HD. So I think there is a major gap in screening, but also generally the capacity of the health workers to manage HD. We've decentralized and task shifted management of HIV. And with HD, we may need to build capacity of the health workers, the lower level health workers, the mid-level health workers, to be able to manage HD. So I think in essence, the capacity gaps as well as the capacity to screen.
The first is the diagnosis of people with advanced disease. And I think we've made, PEPFAR has made some big strides in that department. Initially, CD4 counts were no longer authorized, and now they are in certain circumstances. So the diagnosis is one place. But the other part is the continuity of care, and particularly in the setting of COVID-19, making sure that people with advanced disease get the services that they need and and the attention they need is really, really, really important. One of the biggest challenges, I think, is really sort of the linkages in care from the hospital to the outpatient setting, from the outpatient to the community setting, and how do we get people with advanced disease the right practitioner, the right and all the constellation of services and medications that they need. And so I think that the whole package is very, very important.
So in Swatini, we are implementing services related to advanced HIV disease. Unfortunately, most of these services are based in high volume facilities, including hospitals, health centers, and high volume clinic. So it is important for us to decentralize the services to low volume clinic, which are providing services to almost 40% of all the clients who are on ARVs. So currently we are focusing on high volume clinics, and we are missing clients who are receiving their treatment in low volume clinic, and this is one of the challenges we are facing. And the second challenge is the availability of medicines and supplies used to clients who are having advanced HIV disease. So most of the time, the stock is not constant. Sometimes we are running out of stock, and this is affecting the quality of services which we are supposed to provide to these clients. So this includes the screening, testing, and treatment of clients with advanced HIV disease. That is our second challenge in the country.
From a programmatic point of view, I will say one is case finding. Second is quality of care for those that are found abroad and brought into care. Case finding that has been very, very challenging all over the world. Men, adolescent girls, and young women form a critical and difficult piece in finding and getting onto treatment. And then for those who are identified and brought into care, keeping them in treatment is also been a huge challenge. Retention at 6 months, at 12 months, and 24 months, the cascade goes down along the line. That's why, in my view, it forms a very significant and a very important piece in the entire epidemic control effort. Finding cases, getting them to treatment, keeping them on treatment.
I would say missed identification of some persons with advanced HIV disease because of limited CD4 availability, or maybe even how to deliver certain components of the advanced HIV disease package of care without CD4. A lot of training can counteract that. I know Uganda and Lesotho are both examples of countries that have trained their healthcare professionals to address that challenge. Another challenge is really lack of commodities for diagnosis, such as TB, LAM, or CRAG commodities, as well as management of opportunistic infections, specifically for cryptococcal meningitis.